Ladies and gentlemen, I'm Lucretia B. Taylor from the second year physiotherapy class. Now I'll be discussing on the topic muscles of respiration. So, what are the muscles of respiration? Concerns explosion of the muscles that power breathe growth, intervention, assessment, that function, and rehabilitation. So, I'll be talking about the mechanical the mechanical the mechanics of breathing. The mechanics of breathing and overview. Breathing is a coordinated pump, chest wall, diaphragm, and abdominal wall. Change volume to move air. Inspiration. Inspiration creates negative interthorax pressure. Expiration is passive as rest and active during execution. Key phrases: inspiration active muscles, contraction, expiration passive repo or active with expiratory muscles. Primary contributor: diaphragm, intercostal, extensor muscles when needed. Then we talk about the functional outcome of teams coordination, gas exchange, and airway clearance. Primary inspiratory muscles. The diaphragm and internal intercostal, external intercostal are the chief driver of third inspiration. The diaphragm structure single muscle tenuous sheet with central tendons. Active discrete on contraction. Increase vestibular torus volume. Intervention private nurse C3 to C5. External intercostal raise rib and expand anterior posterior diameter. Active during quiet and deeper inspiration. Then we'll talk about the accessories inspiratory muscles. Accessory inspiratory muscles. Which may occur during increased phonatory demand or respiratory compromise. The sternoclavicle, the sternoclavicle muscle involutes screen and upper ribs, promotes during labored breathing. Scardins elevate first two ribs, symbolize neck during forceful inspiration. Prepostural medium can lift ribs when shoulders are flexed, useful in severe respiratory infects. Expiratory muscles. Expiration in passive at rest. Active expiration uses internal intercostal and then abdominal wall muscles to increase interthorax pressure and expel air. Internal intercostal depress ribs and reduce thorax volume important for force, expiration, and cough. Abdominal muscles, rectus, rectus abdominis, external and internal oblique, transverse abdominis, compress abdominal contact, push diaphragm upward, vessel for coughing, speech, and up and high effect inhalation. Neutral control of respiration, automatic RAM and voluntary modulation are integrated part brainstem, central and peripheral sensation. Brainstem, brainstem centers, modeled Raymond generation and tone modulation. Peripheral impact, central and peripheral receptors, peripheral sheath receptors, proprioceptors. Motion pathway, prephatic nerves to diaphragm, intercostal nerve to intercostal muscles, accessory pathway for neck muscles. Practical application, palpation, and assessment. Quick, reproducible techniques to assess muscles function and chest mechanics. 1. Positioning. Patients sit on supine, observe breathing pattern and symmetry. 2. Palpation point. Diaphragm, supracostal, hand placement, intercostal, lateral rib, spray, skillness, SCM lateral neck. 3. Functional test. Stiff test, maximum inspiration, expiration, pressure, cough, strength, chest expansion tips. Use gentle pressure and synchronous palpation with the respiratory cycle for accurate assessment. Common receptor, common respiratory muscles deficient. Weakness, fatigue, or imbalance in respiratory muscles affect formulation, cough, and exercise tolerance. Diaphragmatic deficient causes penic nerves injury, neuromuscular disease, mechanical disadvantage, orophenol reduced fatigue capacity, accessory muscles overuse, chronic weakness, links to fatigue, neck pain, and inefficient, inefficient breathing pattern. Reduce expiratory force, impact cough, secretion clearance, raise infection rates. Strengthening and rehabilitation exercise. Programming goals restore strength, endurance, and coordination muscles and coordination of respiratory muscles. Diaphragmatic breathing, slow deep breath focusing on abdominal expansion starts supine progressive to upright functional position. Inspiratory muscle training. Darshu loading devices to increase inspiratory strength and endurance. Prescribes rates and intensity. Expiratory strengthening, huffing, coughing, training and abdominal resistance exercise to improve cough pack flow. Program tips and progress low, gradually model symptoms and measure outcome. PR, MRP, MEP, VC, cough pack flow. Key takeaway and questions. Diaphragmatic and external intercostal are primary inspiratory muscles. Accessory and expiratory muscles support increased demand. Neutral control integrates automatic and voluntary impact assessment, target functions and coordination, practical palpation and progression training, restore function, reduce symptoms and improve airway clearance. Question: which assessment or exercise will you like a practical demand for? Please answer this question while watching this video. I hope you enjoy my presentation. I want to take this time. I want to take this time to thank you for watching. Bye.